Gary Ho. I'm a family physician and sports medicine fellow with Fairfax Family Practice in Fairfax, Virginia, in association with Virginia Commonwealth University. I'd like to take this opportunity to briefly review the cardiovascular screening portion of the Pre-Participation Physical Evaluation, or PPE, for sports and exercise participation. And thank you for your interest in the health of our athletes.
One of the primary goals of the PPE is the detection of conditions that may place the athlete at undue risk for participation in sports. This can be difficult in the asymptomatic athlete. Unfortunately, the first sign of a life-threatening cardiac disorder may be sudden death. The PPE provides the opportunity to intervene with appropriate treatment or referral to prevent such a tragic outcome. The American Heart Association recommends cardiovascular screening during the PPE in all high school and collegiate athletes. The 36th Bethesda Conference provides recommendations for screening and clearance of athletes with cardiovascular issues. Another useful resource is the Pre-Participation Physical Evaluation Monograph, available in its third edition. This is comprised of recommendations from 6 major medical organizations regarding the pre-participation evaluation of active individuals. These, as well as other resources, are included with this video. A thorough collection of medical history questions that athletes and family members can readily answer is essential. Highlighted here are the questions specific for cardiovascular concerns on the Virginia High School League's PPE form. The physician can then review the answers, ask follow-up questions, appropriately direct the physical exam, and further evaluate the athlete for any potential cardiovascular issues. Some questions are especially important and may warrant verbally reconfirming their answers. These include: have you ever passed out or gotten lightheaded or dizzy as if you were going to pass out with exercise? Have you ever had chest pain, irregular heartbeat or chest fluttering, or shortness of breath worse than would be expected during exercise? Has anyone in your family died suddenly of a heart problem or died for no apparent reason? Do you take any stimulants or supplements? Answers that place the patient at higher risk for cardiovascular issues may warrant further workup and/or restriction from participation. Checking the athlete's height, weight, and body mass index allows one to screen for Marfan Syndrome and obesity. Further screening, workup, and follow-up for related disorders like hypertension, hyperlipidemia, and diabetes mellitus is then made possible. The athlete's blood pressure should be measured with an appropriately sized cuff, and if initially elevated, the blood pressure should be rechecked after allowing the athlete to sit quietly for 5 minutes. In general, athletes 18 years or older with a BP greater than 160/110, adolescents with a BP greater than 140/90, and younger athletes with a BP greater than 95th percentile should be restricted from participation for a full hypertension workup. Lower risk athletes with blood pressures below these values may generally participate, but should have their blood pressure monitored and may warrant a hypertensive workup as well. Both the left and right radial pulses and the left and right femoral pulses should be assessed for symmetry. To screen for an aortic coarctation, assess for major differences between the radial and femoral pulses. If the exam is suspicious for aortic coarctation, restriction from play and further workup are indicated. At the very least, the 4 major cardiac auscultation areas should be assessed, including the aortic, pulmonic, tricuspid, and mitral areas. This should be performed in the supine as well as in the sitting or standing positions. The presence, character, timing, duration, and intensity of murmurs should be noted. Extra heart sounds such as an S3, S4, or clicks should also be noted. Dynamic maneuvers are also important to further evaluate and uncover hemodynamically significant cardiac murmurs. The stand to squat maneuver accentuates the murmur of aortic stenosis and dampens the murmur of hypertrophic cardiomyopathy. The opposite occurs with the squat to stand, as well as the Valsalva maneuver, dampening the murmur of aortic stenosis and accentuating the murmur of hypertrophic cardiomyopathy. Indications for further workup and/or restriction from participation include the presence of harsh systolic murmurs with an abnormal dynamic exam, murmurs with an intensity grading of 3 out of 6 or higher, diastolic murmurs, or extra heart sounds. The use of electrocardiography or EKG, Holter monitoring, and echocardiography as screening tests for low-risk asymptomatic athletes is controversial. However, there is no good evidence to support their use for screening purposes at this time. Nonetheless, these tests should be considered as part of a cardiac workup when indicated. Marfan syndrome is an inherited autosomal dominant connective tissue disorder with important cardiovascular implications for athletes. Particularly, Marfan-associated aortic root dilatation can lead to aortic dissection, rupture, and sudden death. Individuals with this disorder do not always present with a classic phenotype, so family history is important. The screening criteria for Marfan syndrome include a family history of Marfan syndrome, or males taller than 6 feet or females taller than 5 foot 10 inches, and at least 2 of the following: myopia, high arched palate, kyphosis, pectus excavatum, arachnodactyly, thumb sign, positive if the completely opposed thumb within the clenched fist projects beyond the ulnar border of the hand, wrist sign, positive if the thumb and the little finger of the same hand overlap when wrapped around the opposite wrist, arm span to height ratio of greater than 1.05, mitral valve prolapse, aortic insufficiency or regurgitation, lanicular dislocation as determined by a slit lamp examination. Refer to an ophthalmologist as needed. This screening process does not diagnose someone with Marfan syndrome, but simply indicates that the athlete needs further evaluation prior to clearance for participation. This includes an EKG and echocardiogram to assess the aortic root, an ophthalmology referral and slit lamp examination for lens dislocation, and a genetics referral.
We hope that you found this quick refresher on athletic PPEs helpful and informative, and thank you for your efforts in keeping our athletes safe.